that's a team of operator today and a complex STEMI with multivessel disease. So again, he had no previous history of coronary disease, had tobacco abuse, dyslipidemia, but we had no lab when he came in with this STEMI. He was transferred from another center after the EKG showed a massive anterolateral MI to us. He was stable hemodynamically, and he arrived at our institution Saturday evening. So again, it was a de novo chest pain that started in the afternoon. Initially, it was in the back, then permanent chest pain, and he was transferred. And I would like to show you the angiogram that my colleague, Dr. Ibrahim, performed Saturday. So this is the first shot that was done Saturday. So you can see quite extensive disease. RAO caudal, you can see the LAD that's totally occluded, quite aneurysm, and then the circumflex marginal that's subtotal. And you can see collateral to the right. We're suspecting an occlusion of the right. So again, now you can see the RAO cranial projection can document the occlusion of the mid LAD with that aneurysm formation. So because of the occlusion, the aneurysm, the thrombus, it was decided a selective use of thrombectomy to try to better evaluate the dimension angiographically, try to establish flow. So you can see that there's reestablishment of flow. It's not normal. You can see past the aneurysm, the lesion, and probably an ulceration. Let's probably do a stent, obviously, to open that vessel because plain balloon angioplasty and Kawasaki, we suspected there was no history, but of a Kawasaki disorder in the past. Stent was placed, and because of the dimension, it was selected a Megatron from Boston Scientific that could grow up to 6 millimeter. It was a 4.0 by 20 millimeter that was deployed there. The stent has been implanted. The flow is not normal, but it's much better than at the beginning, obviously. After the 4.0 stent, there was a 4.5 up to 18 atmosphere that was deployed. And then finally, because the patient was stable, a V-gram was done. So you could see some severe anterolateral apical and even inferior part of it. So this is the angiogram of Saturday evening. So let's go back to our slide, please. I think you can appreciate the multivessel disease with aneurysm formation, with occlusion, potential Kawasaki disorder. I would summarize that the occlusion of the LAD with aneurysm, severe L circumflex with OM stenosis, then a CTO that was collateralized from the left. Successful PCI reopened the vessel, patient ST went down, less chest pain, but had potential thrombus in the apex. That was confirmed by the ultrasound the following day. Ejection fraction was 40 to 45%, and it was about 1 centimeter of apical thrombus. So that will be important in the discussion about anticoagulation versus antiplatelet agent. Probably familial dyslipidemia. Troponin went up to 7,600, went back down. But we started already with high-dose statin, ezetrol, and also we'll have a PCSK9 antibody. Yesterday, we performed PET rubidium that suggests severe ischemia in the lateral, inferolateral, and inferior territories. There was some deficit in the anteroseptal and apical, but from the report, it looked more like stunning. There was actually a good viability in all the segments. So this is good for prognosis. I guess our discussion on CCU was, should we switch him from ticagrelor to clopidogrel, which we thought that was safest long-term for bleeding aspect, even if he's young and has no other risk factor except tobacco for bleeding. So we gave him 600 of clopidogrel yesterday, stopped the ticagrelor, kept him obviously on aspirin. And our plan for today, after discussing with Dr. Doucet, is to image the LAD first to make sure that the stent is well opposed. You could see that there was aneurysm before the stent and after the stent. If it's undersized or if we feel that we need to go back and it's resistant, we could consider some plaque modification. Even after the stenting, we've done sometime shockwave within resistant in-stent restenosis, or let's say in this case, the stent is not well opposed and there's a calcium. This is something we could consider today. As for the CTO of the RCA, this is something that should be considered depending on how the patient will how his evolution, if he has still angina, if he has major ischemia. But for now, it would be at distance of the acute MI. So the discussion in this case is the optimal management of patients with chronic Kawasaki disease. We do not see that on a regular basis, but once in a while we see those multiple aneurysm presenting with an occlusion of a vessel. And what's the status of these patients? Most of the time, the guidelines suggest, based on not that much evidence, that we should treat them as regular ACS, but be very aggressive on the risk factor modification. And if there's multivessel disease, complex anatomy, we could consider a CABG for these patients to bypass those aneurysms. The concomitant familial hypercholesterolemia, the combination of the two diseases has not been reported that frequently that level of LDL. I don't recall seeing a Kawasaki disease with such high cholesterol. So we will treat them aggressively, and we have better agent than ever before. And we have even upcoming agent that can be given every 6 months. So that's something that in the future, I'm quite hopeful that we'll be able to control his LDL level. We discussed the thrombectomy, routine use versus selective. In this case, I think it was appropriate. It was selective use. Imaging will show you in a few seconds the LAD, the stent, and plaque modification. Either in some calcified Kawasaki disease, we could consider, if it's superficial calcium, to use a rotational atherectomy or orbital atherectomy, or if it's more medium, because there's disease of the media. I mean, it's a vasculitis. We could consider, even the data is limited, intravascular lithotripsy. The other big question is, what is the duration of DAPT? Should we anticoagulate these patients long-term for prevention of thrombosis of the aneurysm? The data is not clear. In this case, if we put multiple DES, we have multiple plaque. Clearly, once we stop the anticoagulant after the LV thrombus is healed in 3 months, we could consider to go back with more powerful antiplatelet, such as ticagrelor or even prasugrel.
So that's the LAO today. You see the stent, you see the aneurysm, you see that there's a lesion just before the stent, which was the one of the important points. We wanted to know if it's a lesion which is significative, and we want for sure to know if the stent is well deployed. That's the RAO cranial.
Geographically, the stent looks pretty good, but you see that the vessel diameter is a bit bigger than it was a few days ago. So I'm quite curious to see the IVUS of that stent.
And you see the collateral to the right. You see that we had difficulty to go through the proximal part of the stent. And even when the wire was really down the artery, we're not able to go with the IVUS. So we pulled back the wire. We went a couple of times. And then at the end, I think I was in the right place for sure. And then I was able to go with the IVUS. So we may have go under a strut at the first time. The apposition is good. It's really circular. It's not the two diameter are the same. So we're in the very, very large aneurysm right now. So it's not possible to see all the artery, just one part.
Yeah. And even with OCT, we could not flush very well. So we did not want to use OCT. Initially, we discussed that. We thought that IVUS could give us enough information in this case. And to my eye, I mean, it looks pretty well opposed and within the two aneurysms.
Probably an old total occlusion or a recanalization. It's not as the right completely occluded, but there's a very small channel, I think. We had difficulty because the left main is very, very short.
So we use which wire you selected?
So we tried first a cyan blue, which was so the same one we use in the LAD, and then we could not go through the first occlusion, so we went with a pilot 50.
This pilot doesn't go, but it looks like it's progressing now. You're making progress. Sometimes we could use a small balloon to help also. This one is a pilot. I think it has good, safe approach. Fielder could be another option also. Hydrophilic polymer jacket wire that are very good at crossing those recanalization. So
we'll try I think we'll try the Fielder XT.
It's interesting that the patient had no real chest pain except the novo, initially in the back, but then after that, crushing pain in the chest. So let's go with the Fielder XT. And now you can see the aneurysm. So IVUS, in this case, prevented us from going post-dilate in the LAD. Focus now on the circummarginal. So somewhere between 2.5 to 7.5. And obviously the cause of Kawasaki is not known. We treat maybe acutely in young patients with immunoglobulin who try to reduce the inflammatory or autoimmune reaction. But the incidence is low, and North America is 25 per 100,000 patient. Obviously in Japan is about 10 times more, 250 per 100,000 population. He has lipid. This is also important, I think, in this patient to try to modify the evolution of or the recurrence of event. Now with the Fielder XT, I think it should track better the microchannel and hopefully have the strength to.
Yeah, my gather is well in the going through the circ, so it's easier now.
Gives you more support with the guiding and the wire. For this, you have to be patient. I mean, it's nothing to be rushed. It has no pain. It's very stable. Find the channel and.
So I was able to go through a very small branch, which was going just at the 90 degrees angle from the circ. And then I went to the distal lumen, but the pilot went through, I would say, a little bit more easily. It's this. Yeah, I'm stuck in the aneurysm. That's the thing. That's why I'm not advancing. It may be easier for the pilot to go.
Yeah, and the pilot gave you good support at the beginning.
Yeah, I had a better feeling with the
pilot
50.
Yeah, we could try to increase.
I'm not going as far as I was with the pilot.
With the pilot, huh?
So I'm at the same place I was with the pilot. So I need to pull back and try to go. That's where the Fielder can make the difference.
Obviously, you don't want to test too much, but at the same time, I think the angulation looks good. Looks promising in this view, but you may not have the pushability because the wire is. Sometimes I use either a little balloon to help me or a microcatheter to try to give a bit more push and
okay.
maybe that's an opportunity.
Yeah.
So again, these techniques obviously at high level CTO to try to get access anterograde.
Turnpike.
So we'll try a microcatheter with the Fielder XT, and so that kind of take time to focus on that. The wire is still okay. And obviously we're selected to try to reopen the 3 vessel. Now the LAD is okay. Now the circumflex and next time the RCA. With the wire, with the catheter, we have better pushability. Obviously the wire is usually very flexible in the microchannel also, hopefully to get back to the distal vessel.
Okay, so that's the same problem when I'm on one side of the aneurysm. I need to go on the other side.
I think you can appreciate the wire movement and the precision.
And I change a little bit the tip.
This one of the branches, or
no, not yet. No.
That's coordination to try to get to that lumen. Still not sure.
I see the catheter.
As we need, I mean, we can change the tip, we can change the wire. For now, I think it's well engaged.
Push me in.
On the side, yeah. So sometimes it helps, but now the angle is, well, I think that's good with the wire. The pushability. The other thing is you could consider looking at the spider to see also the angulation. But I think in this view, you saw well where to go. And this is where you need patience to kind of have success.
So I look with the test if I change anything. You see, he's already more direct to the lesion.
Yeah,
he went through the aneurysm easily.
Yeah, good control. Yeah, that looks close.
And there's another aneurysm.
Yeah. That's a small branch. Huh? I think the take home also is that Kawasaki disease brings a complex calcified occlusion aneurysm that makes it difficult to maybe getting it out, more difficult to recanalize. We've used sometimes laser in some very resistant lesion in Kawasaki disease because they're calcified. We thought about using intravascular lithotripsy, but in this case now we will focus on getting the wire across and see after that. Try to open with a small balloon and then go slowly.
Yes.
To rupture the vessel.
So what are the next steps? Keep with the microcatheter and switch for another option of wire.
I think if I'm convinced that I'm in the right direction, I will use a more stiffer wire, but I would check probably in 2 angles to make sure. But it looks really promising. Control your wire, and you were in the small branch, so I'm sure you're in the probably micro channel. And
you want to look at the spider view?
But just take one shot, maybe just to see.
Menu dans spiders.
Spider, and then that gives you some time, another appreciation of the angulation for your wire. And before pushing with the stronger wire, I like to see both views. Well, there's still quite a long segment.
So, one problem is that with the aneurysm, the microcatheter, when I put it, it's going in the not in the right direction, and it pulled back my wire because of that. So we may work with it and try to put it in the distal of the aneurysm. Yeah. Because I lose a lot of
power. Pushability.
Pushability with that.
Okay, so that helps.
Faites
maybe in trying to orient the macro.
You see, I have almost a 90 degrees angle, so for sure my push is not as it has to be to go through. But that's why I'm stuck here. So what I would do in the next minutes, try to push the microcatheter down the distal part of the aneurysm. But there's a risk of, again, the guider going.
The guiding, yeah.
Guiding going out. Huh? Yeah. Yeah, go ahead. Oh, so you see the guiding is going out.
Yeah. The other thing is to change guiding also, like an Amplats, but for now I think you have enough comfort moving the guiding, the turnpike.
But you see that the angle is like this.
Yeah, that's better a bit. It made a bit of progress, I think, the wire now. A few millimeter. Yeah, I think so.
We did the first part of this case, by the way. We'll keep working on it for sure.
But it shows you the complexity in a young 37-year-old man with a STEMI, but combination of Kawasaki disease probably in the past. Asymptomatic, we don't know. I tried to ask him the question several times. Severe dyslipidemia. And so now we have aneurysm, multiple aneurysm, occlusion, calcium. I think I'm impressed how the good result of the stent and the LAD by IVUS. So the role of imaging, I think, is key in some cases. Now it's more like a CTO approach, and now going stepwise, antegrade with the microcatheter, different wires, being careful, taking our time to really cross that. We're almost there, but there's still a lot of work to do. Thank you very much for your attention. Yeah, thank you. And we look forward to the next case.